everyone. This is Sarah Kalina. On behalf of the Alliance for Aging Research and Talk Nerdy, I welcome you all to this conversation that I'm going to have with Dr. Matthew Peters, who again is going to join us to talk about research. And our goal today is to break it down into pieces so that we can not only understand this particular article, but we can sort of use those skills to analyze other research as well. So welcome, Dr. Peters.
No, thanks, Sarah. Great to be doing another one of these together with you, and looking forward to talking through the article.
Do you want to give a quick introduction so we know?
Yeah, sure, guys. So I'm Matt Peters. So glad that you all are taking the time to watch this. I'm an associate professor at Hopkins in Baltimore in the Department of Psychiatry and Neurology. The director of clinical services for one of our hospitals, Johns Hopkins Bayview. And primarily my clinical and research focus is on individuals with later in life cognitive decline, and maybe a little more specifically, how traumatic brain injury influences that.
Well, we brought you here today to talk about an article which is titled "Where Are Caregivers in the Clinical Trial? Evaluation of Caregiver Responsibilities in Alzheimer's Disease and Related Dementias Clinical Trials." So I want to start with what this is. First thing I do, I look at the date, I look at where it's published, so the Journal of Alzheimer's Association. This is called a short report. Mm-hmm. It's not a clinical trial. What is it?
Yeah, great question. So, and this is probably the first teachable point from this particular manuscript. So it's called a short report. Typically, those are shorter, as the name would imply. Still important takeaways, but often not as long as a full-length research article. Sometimes that work is preliminary or pilot type data. In this case, what we're actually looking at is called a scoping review. There are different types of reviews that we do within medicine. The most structured is called a systematic review, which involves very structured, organized work through an available literature base. There are narrative reviews, which, as they sound, are largely trying to look at a topic and tell a story about the information that is available on that topic, often systematic, but not with the same rigor as a systematic review. And then there's scoping reviews. So typically the idea with these types of reviews are it's a relatively new topic area that the review is going to focus on, something that potentially there's limited academic literature on, but is nonetheless an interesting topic. And usually what you'll be doing is looking at available literature, or in this case, we're actually looking at a registry of clinical trials and trying to see, can you get some initial themes or potentially form initial hypotheses out of what you're looking at and reading. So oftentimes you come into scoping reviews without a hypothesis set down for what you expect to find when you start to look through the data. And it is the appropriate title for what we're about to walk through. These authors thought of an important question, had a database, which was clinicaltrials.gov, that they could look through, then started out with a broad look at the available clinical trials on Alzheimer's disease and narrowed from there. So that's a bit of the background, and then we'll walk through the actual article.
And they're also looking backward. This happened a long time ago, all of these trials, right? They're looking between 1990 and 2021. So their research question relates to caregivers, which is a great question. They seem to have two parts of their question. So the first one is to evaluate the responsibilities of caregivers, and then to examine how they're communicated in this particular clinicaltrials.gov. So let's talk about clinicaltrials.gov. Mm-hmm. I was curious because I was thinking, gosh, it's not that old. It's like it was made public in the year 2000, which of course, for some of us, feels like just a hop, skip, and a jump. I guess for my kids, they wouldn't agree. Let's just talk about what it is. Obviously, it's .gov, so we know that it's a government website. Are all clinical trials listed there?
Yeah, great question. They should be. That does not mean that they are. So largely the registration on clinicaltrials.gov is regulated isn't the right word, but either highly encouraged or required in order to get studies through the institutional review board process at most major academic centers. So, for example, at Hopkins, where I work, when you are submitting a new study, if it's determined to be a clinical trial, you can't even submit the IRB, the protocol for review, unless you have your assigned clinicaltrials.gov number. So they do take it very seriously at most centers, and the idea really is to be keeping track of the research work that is going on. The government, the FDA, the academic centers, to everybody, it's important that when you're recruiting someone for any kind of research study, appropriate, it's novel, you're not unnecessarily duplicating something that may already be happening. So this is really part of, maybe about half of it is a place that researchers can go and make sure that they're not unnecessarily duplicating something, or they know what other trials are ongoing. And then the other half of it is really public facing, and you're able to look through it and see, are there any trials that are particularly or possibly relevant to you, your loved one, etc. Really nice way to do both of those two things. And I do not know the percentage of institutions that require registration at clinicaltrials.gov, but we certainly require it at Hopkins.
It would make sense that federally funded trials, even just partially, would be expected to do that. But
Right.
I don't think that there's actually, there's not a requirement. If someone does a clinical trial, they don't have to tell us about it, do they?
Correct. Putting it maybe the other direction, which is if you're doing a trial that's not registered on there, is your trial going to get shut down? The answer is no. But typically, you can't even move forward with getting something started until you have the proper evidence that it's registered.
A couple terms, actually. One term that we hear a lot is protocol. Would you mind it's not a term that we all regularly use. What is a protocol?
Yeah. And another part of this that potentially gets a little more nuanced is whenever we submit a research study, we have to have outlined what is the experience going to look like for the individual that's entering that trial or entering that research study. And essentially, as you're laying that out and you're thinking through, sometimes as granular as what happens on day one, what happens at week one, what data is collected at all of the different time points. That's part of the protocol, is what is it actually going to look like for the person. But the other part of the protocol is, as you're putting that together, if you identify things like a device you're going to use or a drug that you're going to administer, the protocol is going to refer to those and explain different aspects of the drug, the device, how patient confidentiality is maintained. So it's everything all the way down to that granular, what is it like to be in it? But then as you think through each element of the study, how can you show that this is safe to do with somebody?
And would the directions to, for example, caretakers be included in a protocol?
Some of them. The protocols typically are meant to be internal documents for the most part, meaning there's information that we put together for our colleagues, professionals, etc., to look at the study, have the information they need to approve it, and move it forward. Then you typically have a second set of documentation that's a protocol that explains in way more detail what is your research assistant, for example, going to do when they're interacting with the participant. So in some trials, especially ones that caregivers are part of the requirement to be in the trial, there will be separate protocols listed for what that's going to look like. When we get to the takeaway from this short report, it's pretty clear that that's not all the trials, though.
Yeah. So before we get to sort of the findings, let's talk about this inclusion and exclusion criteria. In some systematic way, we're going to look at what's out there and we're going to organize it in some way that makes sense, and they're going to exclude certain trials and only include others for this analysis. The first thing that popped out right away was the dyadic or non-dyadic interventions, which seemed to me something they definitely should define. So I was like, hopefully you can help me with that, because
I would agree with you. It is not defined well in the publication itself. So what we often do when we're reading through something and we have a question is actually reach out to what's called the corresponding author on the article. And for the most part, and I truly think some of this is guided by what your email address is, to be honest. If you're emailing from an academic institution, people tend to get back to you very quickly if you have questions about their work. Now, anybody is open to email them as well. We love, honestly, talking with individuals about the work that we're doing, clarifying any questions that they might have. So that corresponding author is taking on that role for a reason. It's that there's somebody that is willing and able to respond to requests for information as they're coming through about the manuscript. It is the person that's designated as the corresponding author. That is sometimes, most often, either the first author or the senior author, which is the one that's listed first for the first author and last for the last author. In this case, it was the senior author that was corresponding, and I did reach out to this individual to clarify the dyad question.
Oh, great.
Yeah, and they got back to me quickly because we all can understand that a dyad would signify two people, but the question here was, as they were looking through the studies, how did they classify one versus the other? So they gave me a very straightforward response, which was, if the clinical trial required that both the patient and a caregiver consent to the study, then they called that a dyad study. If the trial required just that either the caregiver or just the patient consented, they considered that a non-dyad trial. Those trials still would have a caregiver oftentimes as part of them, but it was not formalized in a way for non-dyad that both the caregiver and the patient had to consent. So think about the dyad ones as being a bit more probably rigid and organized when it comes down to it, about let's make sure we clearly have our caregiver, we clearly have our patient. They're both informed to the level of being able to get informed consent about the study. So to me, those are going to be the ones that, when you think of evidence-based, they're probably going to be a bit higher than a trial who the caregiver's part of it, but they're just kind of coming along for the ride. It tends to not be as formal.
So we don't have to go through each one of these, but I'm just sort of looking at the types of things that they excluded, and trying to sort of get a sense of why they could do that. They excluded, if the evaluation was of the health providers, they excluded that. They excluded trials that targeted other diseases or risk factors or early onset. So I guess the idea was that would be perhaps a different set of needs in terms of the caretaker's role.
Yeah, I would agree with you. And the other thing that is notable and worth clarifying is that they excluded trials that evaluated the outcomes for caregivers. So the reason why that's important is, it might seem confusing that they're excluding something about caregivers, but it's because you're really looking at who is the subject of the study, and therefore who is the person that you're looking at outcomes for. So an example of a study, let's say it's a study of individuals caring for somebody with Alzheimer's disease. And yes, the patient's there, but who you're actually interested in is the caregiver and intervention, like a support group that you're delivering to them. That would be excluded from this particular analysis. But if you have a study where you're delivering, let's say, a support group intervention to the patient, and the caregiver is part of those conversations as well, that would have been something that's included.
So okay, so let's go there. Let's talk about the findings. So wow, less than half, less than half of the trials that they looked at basically address this at all. Is that right? How do they describe this?
Yeah, exactly. So they landed on a sample of 160 trials listed on clinicaltrials.gov, and of them, 72, which is 45%, had explicitly stated about a caregiver needing to be available for the patient and participating in the trial. And that's where, of those 72, they start splitting out the ones that both the caregiver and the patient were consented, and ones where it was just one or the other.
Right. Right. Okay. There's something else when they looked at the data that I was taken back by, which is the demographics, clinical trial characteristic. So they note that 19 of the 160 entries included racial and ethnic demographic information. What? What?
Yeah, I know.
Is that not a default? I mean, every time I fill out anything, I mean, if I go to the store and fill out a grocery card, I feel like I provide that information. So I was surprised by that, let's just say.
Sure. If the trial is not trying specifically hard to recruit a proper representation of the population in, let's say, the surrounding area, including minority individuals in studies, it has been and remains a major challenge, both on the recruitment side, but also in the way that studies get organized and dispersed and information gets out there. That does not mean there aren't groups that are trying.
Yeah.
And there are specific studies dedicated to areas of the country that have a higher proportion of minority individuals, with the idea being that if it's really just an issue that there's not enough people to recruit from, which we don't think that's all of the issue,
Right.
then if you go to a specific location, you're going to see a higher percentage and a higher number of people. Some of the University of Texas institutions, for example, have done a particularly good job of designing and having studies that are specifically committed to the Hispanic population. But when you look at it as a whole across studies, the number of white individuals remains the vast majority of people that are in the trials, whether it's Alzheimer's disease or other disease states.
So I'm assuming white and relatively privileged people. One of the things that we were reminded as we read this is that being in a clinical trial, especially if you're a caretaker, is volunteer work. And we all have a lot of volunteer jobs. And then we have our paid work. And then we have our kids and our parents and our neighbors who has an extra 10 hours a week to to go
Absolutely.
and do this. That was certainly a take-home message that I got from this. It's that the whole thing is set up as if there is a cross section of individuals who just happen to have an extra 10 hours a week.
Yeah, and that's the part of it that I think oftentimes gets forgotten, is just how committed individuals really need to be to participate in a trial. And that commitment does not necessarily indicate a desire or lack of desire. That commitment is all parts of it, the want to do it and the ability, the time, the resources, sometimes all the way down to where do you live in proximity to an institution that's doing this work. Because trials and research in general is limited by budgets, and it's always limited by budgets for the most part, the studies, even if they want to help with things like transportation, there's limited ability to do that. And I will say that review panels for grants are increasingly thinking about the burden put on the participant, and out of the budget that's going towards the study, what elements are in there to make sure that you're making this as easy on people as possible. So as an example, we had a study that patients got lifts back and forth to the hospital, but then you're you're creating a new scenario that some people have never used, which is getting in the car with a random person to get to the research. And
Can be
so,
kind of disorienting for anyone, right? Yeah, like, wait, who are you? And yeah, that's
so you still potentially end up in a scenario where the person doesn't feel safe or comfortable going on their own. So still they're hoping someone comes along with them, and still then that person has to also be taking time off of, typically time off of work if it's a son or a daughter bringing the person.
Well, just sort of back to the findings. So we obviously learned in the past, there often is, and behind the scene, there's a lot of unpaid work here happening, right? a lot of caretaking in our society is made invisible, but is the power of things like clinical trials and a whole lot of other things. I'm looking forward to having this conversation with the group to see what other people got out of this and what they learned. My question about their recommendation, which was to encourage, I guess, people to include more specific information about how caretakers are expected to be involved. If the problem is a lack of information, then providing information solves the problem, right? But what if the problem isn't information? What if I said to you, so I'd like you to be in this clinical trial. I just want to let you know that you're going to be driving your parent 2 days a week. And I need you to come during rush hour. There's probably going to be an hour wait, but don't worry, I'm providing Oreos.
Right.
I mean, that's information, right? Right.
Right.
As an advocate, I often see that because information is cheap and it's relatively easy and it's not very controversial, right? It's like, oh, well, give information. But is that really what we're looking for? Or are we looking for a whole new way of thinking about the role of budgets, as you say, oh, well, there's tight budgets. Well, it depends on what you start with, right? You start with the people that you have to have and you fit in the other stuff around it. It just depends on what the priority is. Certainly adding another expense to something that's already a tight budget. We've all done that before.
Yep, you are 100% correct. And I like the way you put it, that information is often the low-hanging fruit, right? It's often the thing that, all right, why not add a section to clinicaltrials.gov that you have to highlight what the caregivers need to do? That might bring a bit of clarity, but in some ways it might actually scare certain people away from participating if they see, oh my gosh, this is what I'm about to take on. Now, I think that it is appropriate for people to have a general sense of what something's going to look like. But what I will say is, that when things are shared this way in an asynchronous manner on a website, it only tells part of the story of what the research experience is going to be like. So having people be informed is great, but when you're actually sitting there with the research assistant and the investigator that usually is willing and open to thinking through with you, how do we make you a successful candidate for this study, you often can get through some of that, although not all of it, depending on the resources that the family might have. So I think adding the information, being transparent, can be very important. I don't know if it removes the barriers to participation.
Yeah, I guess that's the so what question. So I like to sort of wrap this up with, okay, so somebody went to the trouble of asking a question. They're thinking about caretaking and how that impacts clinical trials. Great question. They are, highlighting the fact that there's a lot of unpaid caretaking and work that happens to allow people to participate, specifically in this area. And they have, rightly noted that clinical trials in general in this area are not adequately addressing this issue. And then they wrote an article. Right?
They wrote a short
I'm such an advocate, right? Yeah. So and then they wrote an article and a few people read it. So one of the pieces of this that's always hard when we're as research advocates is what next? Who reads it? Who acts on it? Who takes this and says, let's try something different? Who says, well, let's try maybe something prospective, right? Let's say that we'll, do a little bit here and we'll do a lot here, and so we'll do a little better here and a lot better here, and let's see what happens in terms of accrual or something like that,
Yeah. Great. So great questions. So I think there's a couple of things happening in the research sphere right now in general, so some of which tie back pretty nicely to maybe one of the first points that is worth hanging on to from the article, which is there is a public facing side to the research work that we do. And I think that often will get missed. Clinicaltrials.gov registration is often that I got to do that as well while I'm putting the study together.
Right.
Um,
Right.
because you're already doing a ton of internal
Right.
work to get it approved by your institution. And then,
Right.
this has to be set up as well. And not only that, but it, back to that point of not many of these studies actually made comments about the diversity of the people enrolled. When we are updating clinicaltrials.gov, which happens or is supposed to happen on a yearly basis, you can put that information in there, but it's not a requirement to put that information in there. So I think big picture takeaway is, as researchers, remember that there is a public facing side to the work that you're doing. And you're seeing a lot of research groups setting up and designing their own websites at this point to recruit people and get them excited in their research work. And one big change to that has been, instead of trying to use whatever resources institutions have internally, they're actually contracting with companies that creating engaging, informative websites is what they do. And that's a big shift, to focusing on how do we create something that the general population is going to understand and get excited about, as opposed to our old lab websites, which a random student working in the lab would put together, and that's what you would have. So takeaway number one, a reminder that there's the public facing side, and I think that is something researchers are noticing and listening to. I think the second takeaway from this is exactly the point that you were making, which is, it's fine to identify that this information gap is there, that this information gap could be pretty easily fixed, and that you just make it a requirement that you have to put the caregiving information on the website.
Right.
That's not going to be the end of it, though, and that's not necessarily going to improve recruitment in any meaningful way. This became even more important trying to do research during COVID, but the idea of properly not only enticing people, but showing people the value of being involved in your studies, and doing that in a way that you're involving the important people in their life, like that really is recognized these days. So I think we've moved towards a general understanding that involving the other people in the patient's life, if they're going to be involved in a study, is important.
Yeah.
The next step from that, I think, is going to be, if that's the case, then how do we incentivize or make it easier for that other party to be involved? And especially in cognitive disorder research, it's almost become commonplace for a caregiver or someone to be part of the study with the patient, whether it's listed on a website or the person's consented or not. Just like, giving an example of the memory clinic I work in, I can't remember the last time I had an appointment in that clinic and it wasn't two people, the patient and somebody else. My other clinic, which is a general psychiatry clinic, patients come to that by themselves all the time. But this population, whether we're building it into a study or not, someone is helping them get there. Thinking through things like work notes, if someone's taking the afternoon off to bring someone to an appointment, that stuff is all being thought about, but it's often on an individual case by case basis. It'll be interesting to see if funding bodies and other groups start expecting a plan for those individuals that are involved in the research. That would be a really cool step. Plenty of plans that we have to lay out when we're applying for grants, but the feasibility of how are you going to get the person back and forth, it's kind of on there, but often as a hindsight.
Okay, we have to wrap up. I could talk about this for another hour. We have a great group of people who are really looking forward to having a conversation with you and each other, and with each other about this article and the other ones. So Matt, thank you again. I look forward to continuing this conversation very soon.
Thanks, Sarah. You as well.